All right. Welcome, everyone. Great to be here. We are live on Facebook, live on YouTube. Thrilled to have you here for our third edition of the CMV Live. For those of you that don't know me, I'm Rob Tatro. I'm president, founder of the Canadian CMV Foundation and CMV Canada. And it brings me great joy to be here again today to talk to you guys, to build some momentum towards Ottawa 2021, which is going to be the CMV Public Health and Policy Conference. So we're hosting that in Canada. We're thrilled. We're now building momentum up. Until then, one of the presenters, the presenter we have today, really excited. I've known Isabelle for a while. Let's bring her in. I'm going to bring her in and introduce her to you guys. Isabelle Boucoiran, thank you so much for being here today. Obstetrician-gynecologist, co-director of the CIM, which is the Centre d'Infection Mère-Enfant at the Children's Hospital University, in Sainte-Justine. I think I got that right.
Yes, hi, Rob.
All right, great to have you here. A reminder, if you're watching on YouTube or on Facebook, take a sec to subscribe, share it, like it. We'd love your positive feedback, your positive comments. If you have any questions so today, the way it's going to work, Dr. Boucoiran is going to present to us her findings, and it's pretty interesting. I'll get to that in a sec. Afterwards, if you'd like, or during, if you'd like to ask a question, please do so on YouTube, on Facebook, wherever you're watching. We'll be happy to try to get those questions in to Dr. Boucoiran. A reminder, I want to thank our sponsors. We can't do this type of event without our sponsors. So this is presented, obviously, by CMV Canada. We're thrilled to be a part of this. We're thrilled to have as our sponsors Merck. Merck has been a proud supporter of what we do. We're happy to have them on board. The National CMV Foundation, our American counterparts. You guys are rock stars. You guys are heroes for the wonderful work you're doing down there. And obviously NCHAM, the wonderful people at the university in Utah. So we're thankful. We're so thankful for all of our sponsors. Can't do it without you. Enough about me. The presentation that we're having today is really, really riveting because it basically proves, and I don't want to steal the thunder, but it's a presentation on the perspectives of women relative to screening for CMV while they're pregnant. So to me, I'm thrilled that we finally have research on this because I've kind of known all along what the results will be, but obviously we never know until we do it. And Dr. Isabelle Boucoiran actually went through the process of doing the research, and she will be publishing this hopefully very soon in the Birth Journal, which is a journal of obstetrician gynecology, very well respected journal. So really thrilled that you're presenting the information, and this is going to be published. So this is really neat when we're actually on the cutting edge of research. This is, before being published. In my world, in the stock market world, we would call this pre-IPO. Really, really fun stuff. So Isabelle, I'm going to turn the microphone over to you. Thank you so much for being here today. Isabelle Boucoiran, Dr. Isabelle Boucoiran, obstetrician gynecologist, co-director of the CIM Sainte-Justine, and she's going to be sharing her screen and sharing her presentation with you guys over the next 15 minutes. Dr. Boucoiran?
Hi, can you see my screen?
You bet.
Okay, so let's go. I'm really happy to be here and present on behalf of my team, and especially Maggie, who is a resident who worked and initiated this project. So why talking about CMV screening in pregnancy? So screening in pregnancy will mean doing serology in the first trimester, at the end of the first trimester. At the same time, we do HIV, syphilis, and all the other testing. And the aim of this test will be to detect first trimester primary infection. So the objective is not to know whether or not a woman is susceptible, because all women are susceptible. You may know that you can be reinfected by CMV. But first trimester is the worst time to get CMV. It's the time where the infection can lead to severe neurodevelopmental outcomes. So if we catch that a woman had an infection in the first trimester, that's the best time to propose close follow-up and monitoring of the pregnancy. For now, this screening is not recommended by most society, including SOGC or ACOG. Oh, you're going to ask why. So why? Because the results are complex to interpret. And even a woman who has primary infection in the first trimester has good chances to have a healthy baby. Actually, only 10 to 30% of the babies whose mother had an infection in the first trimester are infected. And one of the worries is that maybe these women are going to be really worried about the result and may choose to terminate the pregnancy before getting the confirmation that the baby has an infection. last week I was attended an international conference on prenatal ultrasound, and there was a debate about CMV screening, and actually only 50% of the physicians who attended this meeting thought that screening should be proposed to women. The question we wanted to ask with this study what do pregnant women want? So what do they think about CMV screening in pregnancy? Specifically, we wanted to determine the percentage of pregnant women who have a positive attitude about CMV screening and who wish to have the screening during pregnancy. And we wanted to assess the factors associated with screening choice, including whether or not they were doing an informed choice. We did a prospective transversal study, so basically a simple survey to pregnant women who were presenting at their antenatal screening for Down syndrome between 11 and 16 weeks at Sainte-Justine between June and August 2019. Women who had a history of fetus with a congenital anomaly or an history of suspicion of CMV were excluded because we wanted really women who were not aware and were not worried about CMV. After a consent, women had to answer a couple of questions about what they know about CMV, and then they had to read a brochure about CMV infection and screening, and then a couple of questions about whether or not they wanted to have the screening and various domains, including anxiety about the result. This is the brochure that we have developed with our Centre d'Infectiologie Mère-Enfant team and with the help of 2 patient partners. I'm not going to go through the document, but it's a very dense document. The woman had 15 minutes to read it, and the research assistant was sitting next to them and could answer any question about the brochure while women were attending in the waiting room. The questionnaire had several dimensions, including, as I said, anxiety, but also risk perception and screening choice, and the motivation for the screening. So basically, how much the women were willing to pay to get the screening, and deliberate decision. So how much women were weighting the pros and cons of the screening. We approached 310 women, and 234 participated in the study. I say Rob, as we could expect, most of the women, actually 74%, wanted to have the screening, but 17 of them didn't know, even after the information, whether or not they wanted to do the screening. The positive attitude was assessed using a Likert scale, asking about whether or not, for instance, the screening would be beneficial or harmful. Most women also thought that CMV screening would be had a positive attitude towards CMV screening, and 21% of them had a neutral attitude. We decided to compare the characteristic of women who choose the screening here and women who actually decline the screening. Age, ethnicity, and working in a healthcare or childcare setting, whether or not they accepted Down syndrome, it was the same pattern. However, as you can see, in the group of women who declined the screening, a lot of them actually were living with a child less than 3 years old, which is a risk factor for CMV infection. And despite that, most of them declined the screening. And also, you can see that in the group of women who choose the screening, even though it was not significant, a higher proportion of women were already aware about CMV before the study. This is the steps towards an informed choice. So for a person to do an informed choice, we need to make sure that the choice is value consistent. For instance, the woman would choose the screening as a positive attitude towards the screening. The person needs to have a good knowledge or good understanding of the screening, have a deliberate decision, so as have weighted the pros and cons, And these 3 dimensions are necessary to do an informed choice. So in the study, we here compare the woman who chose the screening in blue and the woman who declined the screening in yellow. As you can see, the women who accepted the screening were doing a value-consistent choice more frequently, and also had a deliberate decision significantly more frequently. The informed choice was done only by 54% of the women in the group of women who choose the screening, and 30% of the women in the group who declined the screening. So it's quite low, but when we compare that with studies on screening for Down syndrome, for instance, it is what we expect in the prenatal counseling. And you have to remember also that in this study, a lot of women never heard about CMV before. So they didn't have a lot of time to make their mind about screening. And I guess that's why the percentage of deliberate decision was also low. We also compared the risk perception and the severity perception between the two groups. And not surprisingly, the women who choose the screening had a higher perception of risk and of severity for CMV, and also a higher anxiety. However, in both groups, the anxiety scale was very low. So it was not an important anxiety related with the screening in both groups. We put all this data together to try to predict what was really important to choose for CMV screening for women. And in this multivariate analysis, risk perception and severity perception were the most important factor, while anxiety and making an informed choice were no longer significant in our study. So as a conclusion, most pregnant women in our study wanted to have the screening once they were correctly informed. And for me, this supports as a physician that we should at least offer the option for screening to pregnant women and not assume and take the decision for them. However, the knowledge about CMV is very low, and we need to develop specific tools to communicate about CMV screening, mainly basing on our education on risk and severity perception. And thank you all for your attention, and I will welcome any questions.
Okay, that's really, really interesting findings. So if we go to the findings, basically, so when you see the numbers on the charts here, we're talking about the what do you guys call it? The P factor, and you want to see the smaller numbers, the more likelihood that there is a correlation when you're doing this research.
Exactly. So the P value needs to be low and less than 0.5 to see that it's significant.
So clearly, if there was a perception of risk, or if there was a perception of severity of the impact in the baby, not in themselves, right? For the moms, in the baby.
Exactly.
Then they were more likely to screen. So what is the end game here, Dr. Boucoiran? So we screen in the first trimester, weeks 11 to 16 for these babies. We know that women want to get screened. What do we do with that information after? If you were trying to make this mandatory, what would the argument be after that?
So I think the first step is to incorporate that in our SOGC guidelines about CMV. But as I said in the beginning, not all physicians are convinced about that, and there is some downside about screening, especially anxiety about the result, and maybe some decision about terminating a pregnancy, even though the baby is healthy. So, and we need to make sure that the physician, if the decision is to screen or to offer the screening, we need to make sure that the physician are properly trained to understand the result and advise the woman appropriately with the result. Because I don't want to trigger too much anxiety to women, even though in most of the situation, even after a primary infection, the baby is going to be healthy.
Right. So really, if we go back to slide 3, the one that we want to focus on are the IgG plus minus and the IgM positive ones. Those are the ones that are likely to be or more likely to be a risk of confirmed congenital infection, right? So let's say that's 30 to 40%. Now we know that they have a confirmed congenital infection. I think the argument for parents would be, we want to know. We have a right to know. These are our kids. It's in our belly. It's not in my belly, but it's in my wife's belly. And we have a right to know as parents if there's a pre-existing condition in our baby, right? And then what we do after that, I think, would be extremely wide, right? You might, for some babies, you might recommend close follow-up, maybe treatment at birth, maybe, for some you might suggest in utero treatment, or no? Is that something that we're...
So you're totally right. So I think that the parents have the right to know, and what they're going to do with the results, it's up to them. So they may choose to do an amniocentesis to know whether or not the baby is infected, but they may also decline it and just want to have regular close follow-up with ultrasound. But what we can offer them is some treatment to decrease the likelihood of infection of the baby. This is really recent studies, and only one randomized trial which show that high level of valacyclovir can decrease the likelihood of infection in the baby. So what I'm doing already right now in situation where I have a early positive result is to offer this treatment to pregnant women.
Prenatally.
Prenatally.
Okay, yeah. So I know that is, I know there's a lot of studies happening on prenatal antivirals in the baby or in the fetus. I know there's some research on that, but that's still, I would say, somewhat contested, right, in the medical community? Or no, am I wrong on that?
So there is one RCT, but which show like really positive results about preventive treatment. So once a woman is diagnosed with infection, early treatment to decrease the likelihood of infection of the baby. The RCT is good, but it's small. So usually in science, we need to replicate this result to be convinced. Or we need to replicate that result with other RCTs or with cohort studies. It's not decided and it's not definitive yet, but I know that in some countries, like in France, some sites already are doing this protocol and they have good results. So okay. As a physician, if I'm not a scientist, but as a physician, I would offer this treatment to a pregnant woman.
Yeah, and I know that anecdotally from a lot of parents, I think of, the Robinsons in Alberta, and I think of a lot of parents in the US that have had prenatal antiviral treatment, and it's worked wonders for their child, right? I know anecdotally it's working well, and I've heard that as well. I wasn't sure where we were with the research. Okay, so now we have a risk of a primary infection. We're either going to do an amniocentesis to find out if the baby actually, if the infection was transmitted to the baby, and then we're actually going to potentially do that. And if not, at an absolute minimum, the parent has that information, even if the baby is asymptomatic, right? And even if we do, would we know always if there's an infection in the baby, or what percentage of time would you do an amnio in these types of situations?
I would offer an amniocentesis in all parents with primary infection during pregnancy, but it's their choice to accept or not.
And what's the likelihood of the transmission on a primary infection from mother to baby?
So it depends the timing of the infection in the first trimester.
Roughly.
So if it's really early in the first trimester, it's only 10%.
Yeah.
At the end of the first trimester, it's more 40%. So on average, 30% would be the good number.
30%. Okay. So now we have a 30% likelihood that the baby is going to be infected. And of that 30%, then, we know we've covered this in our other episodes, and you can go to our YouTube channel and find out kind of the likelihood and what that structure looks like, what the tree looks like. But there's going to be, 10 to 25% that are going to be symptomatic. There's going to be a portion that are going to have, later onset hearing loss. There's a portion that are going to have vision problems. There's a whole bunch of sequelae that are going to come after that. And again, I'm just going to say, as a parent, we want that information. We want to know, if I want to know if I had a primary infection, I want to know if to monitor my child for hearing loss, et cetera. It's the same argument for universal screening, except it's earlier, right?
Exactly. But one of the arguments of people who don't want to push to move forward the screening is that part of the congenital infection are due to reinfection, and this test is not going to be able to catch reinfection. So in the parents, in the situation we have positive antibodies but no IgM, we're going to have to tell the parents you're not at high risk, but there is still a risk. This risk might be 0.5%.
Yeah, that's like 1%, right? Something like that.
Or less, but it's still there. So
yeah.
This is what people have to remind when they choose a screening.
Yeah, the argument against it would be, the maternal anxiety, the parental anxiety, and what are we doing to these poor parents that are going to find out that there's a 1% chance that their child, may have a serious birth defect. To which I would say, again, we have an IgG plus minus or an IgM positive that is going to give us a 30% likelihood of having an outcome. That's the outcome we want to target on. That's the outcome we want to focus on. What would you say to the naysayers who would say, Dr. Boucoiran, this is going to create a whole bunch of abortions?
So my feeling is that physician or care provider need to be properly trained. We do that every day for Down syndrome screening. It's routine. We offer Down syndrome screening. Some women screen positive, and they know that they have to wait for the result of the amnio before choosing what they're going to do, because it's only a screening test. So I would really try to advise that this CMV test should be considered as a screening test and not as a diagnostic test. And if you explain that to patients, they can understand that's exactly the same process as Down syndrome.
There's a precedent in place, and there's a process that currently exists already, is what you're telling me, and we would just replicate that.
Exactly.
What percentage of moms currently take the Down syndrome screening test?
In my practice, 90-95%.
90-95%. And the numbers that you get from a Down screening test, is it comparable to the outcomes of the CMV screen, or would it be kind of higher likelihood?
Oh, it's higher likelihood.
Okay.
It depends. No, it depends. It depends because they get a number. For Down syndrome, they get a number. It's 1/300, 1/50. So they can also choose the amniocentesis based on this risk assessment. While with CMV, we're going to only tell them, so you had a primary infection, so there is a 30% chance, but we cannot give them more precise estimation.
Why are we so worried about the primary infections in the first trimester? Why wouldn't we screen in the second or the third trimester?
Because the first trimester is the worst time for the fetus to be infected. That's the time where progenitor cells are creating the brain and the hearing system. So when there is infection in the first trimester, that's when there is a highest chance of severe outcomes in the infants. And actually, infection in the second and the third trimester didn't show, in recent study, didn't show adverse outcomes at all.
Yeah, basically the rule of thumb is the later you get it, you get the infection, the later you transmit it to your baby, the better your child is going to be, the less negative outcome he or she's going to have.
Exactly.
Yeah. Okay. Well, I've asked you a lot of questions, and I know we had only booked about 20 minutes for this, and I kept asking because I do have a ton of respect for the work you do, Dr. Boucoiran. I'm proud to have you here in Canada working, and I believe that the published authors on this paper are Lallier Baudouin, Christian Renaud, Marc Boucher, Fatima Kakar, who's we know quite well, Dr. Soren Gant as well, who's in Montreal now, and yourself. So a bit of a superstar lineup there of researchers that put this research together. So thank you for doing that. Thank you for putting this through. Hopefully we do see some change. In your mind, what's the best case scenario for prenatal screening for CMV? Like when do you think it's possible that we'd see that?
If it's accepted in the SOGC guidelines, we should start next year.
Okay. Well, that's great. I like your optimism. That's fantastic. So I do want to thank you for taking the time. Again, I want to thank our sponsors, CMV Canada, Merck, the National CMV Foundation, and NCHAM. I want to remind viewers out there, if you're watching on YouTube or on Facebook, please take a sec to subscribe. Please take a sec to share. If you're a parent out there and you want to get involved, you want to be involved, we currently have parental advisory committees being formed in the provinces. We had a meeting in Ontario, wonderful group of parents in Ontario that are going to start to do lobbying, raise awareness, do some fundraising. If you want to get involved at any level, whether it's, the level I am involved at, which is a lot of work and a lot of hours, or, you just want to do a little bit of fundraising, a little bit of awareness, we got room for you and we need you. We got a parent group in Alberta that's being formed. We got parent groups in Quebec, La Belle Province. It's happening throughout the country right now. And if you're a parent and you're watching, please reach out to us. Go to our website, cmvcanada.com. Go to their Facebook page, go to our Twitter, our Instagram, wherever, reach out to us. We will find you. Once you reach out to us, that's a reference to Wedding Crashers, for those of you that didn't get it. And we'd love to have you on board as a parent. So again, you guys do great work, Dr. Boucoiran. I'm thankful that you're here. Thanks for all the viewers. We're back in 2 weeks today. We have a wonderful lineup of guests all the way through. The presentation is going to be on Wednesday, November 11th. It's basically the Florida CMV collaboration and another approach to impacting change. So that's going to be on the advocacy side of what's happened in Florida. They've had some success in the U.S. We're back in 2 weeks. It's always Wednesdays, noon Eastern. Thank you for tuning in, guys. And I appreciate you taking the time, Dr. Boucoiran.
Thank you, Rob. Thank you for all this work.
Have a great day and nice work. Keep up the good work.
Bye-bye.